So I don't know that I've ever had the privilege of introducing a knight. And indeed, we have with us Sir Andrew Dillon, who is the Chief Executive of the National Institute of Health and Healthcare Excellence, a role that I understand he's had for quite some time, which is really quite spectacular. So we're very proud to have you with us. He's had a number of executive roles, and I won't go into all of them. You can read about them in the app and other places, but let me just give you a short preview before we hear from Sir Andrew himself. First of all, the name of his talk is The Innovation Pathway, and I love this title because it's talking about aligning ambition for successful adoption of new health technologies. And of course, we know that ambitions are not always aligned, right? We have competing aspects to our business. And of course, when you're thinking about aligning that, it's very important to think about why that is important, how misalignment can be fixed when it happens, when goals are competing and resources are in play. It's very important to understand the dynamics. So, Sir Andrew, let me invite you to the stage. We'll hear your keynote address, and then we'll come back and invite our panelists.
Thank you very much, Deborah. Good morning, everybody. It's wonderful to be here in Oman, my first trip. So thank you very much to the Federation for inviting me here. I'm very conscious that I work at a national level in the UK healthcare system, so my perspective in that respect is a bit different from those of you who work at a hospital level. But for the first half of my career, 25 years or so, I was working in hospitals, and before I came to the organisation I'm going to talk about this morning, I was Chief Executive of St George's Hospital in London. So I get what it's like to be on the receiving end as a hospital manager of all of the stuff that you have to think about that comes from all of the agencies, all the national systems that have an interest in what you do at a hospital level. So although I'm going to talk about the business of, as Deborah was saying, about aligning the ambition that we have, those of us who are interested in running bits of the healthcare system, with the ambitions of the life sciences industry from a system perspective, I'm very conscious of the critical importance of those who deliver services at a local level have in getting the best technologies to patients. So just to kick off, it's a little bit of information about the organisation that I'm responsible for. It's called the National Institute for Health and Care Excellence. Doesn't quite fit the acronym now, but the acronym was so good, nice, we thought we'd keep it anyway. Set up just over 20 years ago, and as you can see, its core role is to convert evidence into something useful for decision makers, people who are working with patients, with service users, making decisions frequently in circumstances where there's real uncertainty. So we can help. We can't force decisions, we can't require people to follow guidelines, but we hope we can reduce some uncertainty and form that critical conversation that goes on between health professionals and patients. And one aspect of what we do is to evaluate new drugs, new devices, new diagnostics, and now increasingly new digital health technologies to provide some useful advice, again in circumstances both of uncertainty and in some cases really significant cost, to help inform decisions about the use of those new technologies. And appraising new drugs, but this will be the same really for devices and diagnostics and also for new health technologies. This is the core of the approach that's taken. And there's something particularly unique about this for NICE. This is an approach that's taken by agencies who are involved in health technology assessment around the world. It's pretty common for this approach to be taken. And the two critical lines there, I think, are those in red. Because if you really want to provide really objective advice to decision makers, you need to understand the therapeutic benefit, the incremental therapeutic value of a new technology. What does it offer patients beyond current standard practice? What is it that's new and different and valuable about a new technology? And then if you care about the way in which your health system or your institution uses its resources, you've got to have some understanding about whether that incremental therapeutic benefit is worth what you're being asked to pay for it. So you need to take some approach to establishing value for money. You need to understand the cost effectiveness of the technology that you look at. And there are lots of different ways in which you can do this. But the approach that has evolved, and this again is a pretty international approach, is to get an independent, that is, independent from the provider of the technology, and ideally independent from the political system that the healthcare service is operating in, perspective on those two things. And the best way to do that is to bring together a group of people who can provide both knowledge and perspective and understanding of the needs of patients and of the healthcare system together, to look at the evidence as an independent advisory body, and to collectively come to a decision, a judgment on those two things, the clinical effectiveness and the cost effectiveness of the technology. And determining cost effectiveness, again, there are a variety of different approaches, all based around economic modeling, but the one that is used at NICE is to establish the incremental cost effectiveness of the technology by using quality adjusted life years, measuring the additional QALYs gained by a new technology, and looking at the price per QALY, and then setting that against a standard threshold. It's almost a willingness to pay on the part of the healthcare system. And in the UK, there is a pretty standard threshold of around £20,000 to £30,000 per quality adjusted life year. Below that, the system generally regards a new technology as providing value for money. Above that, there may be circumstances, exceptional circumstances, where it's still the right thing to do to provide the technology. But as you go above that level, then effectively you are taking away some of the resources that could be used more effectively elsewhere in the healthcare system to provide that new technology. But this is all about choice. This is where there are no absolutes in terms of deciding how to use new technologies. This is where what ambitions the health system has, what judgments it makes about new technologies and what its priorities are, all come into play to help inform that judgment about when it's the right thing to do to introduce a new technology at a given price. So just to illustrate that point about cost effectiveness, again, this is very much a UK approach. It's different in different countries. It doesn't have to be this way, but generally speaking, up to about £30,000 per QALY, our advisory committees would say yes to a new technology. Above £50,000 per QALY, it's very unusual for new technologies to get into the UK healthcare system. There are some exceptions for technologies, for drugs that are designed for ultra-rare conditions where there's a separate threshold and a separate scale beginning at £100,000 per QALY and going up to £300,000 per QALY. But these are for technologies that are designed for conditions that are so rare that in a country like the United Kingdom, there may be only 2 or 3 families with an inherited genetic condition. And in those circumstances, the premium that companies are looking for, the price that companies will sell these products globally, means that we have to look at them differently. Otherwise, we're simply excluding the use of those technologies in the UK. But for most of the new things that the life sciences industry is bringing, this is the scale. This is the scale that we use. Now, here you can see that there are some technologies that fall between these two extremes, where above £30,000 per QALY, there may well be exceptional circumstances for our advisory committees to take into account. They may feel that there are aspects of improvements in quality of life, benefits to patients, or for the healthcare system that are not captured in the economic analysis. And so they can effectively provide some credit for that in circumstances where the apparent cost effectiveness of the technology is above that £30,000 level. And there's a specific circumstance in the UK where this is routinely considered for treatments for cancer treatments regarded as a priority in the UK. And a special fund has been established, I'll come back to that in a moment, a special fund has been established that enables new cancer technologies to be introduced into the system in specific circumstances where there's real uncertainty about the value of the technology. If you look back over almost the 20 years or so now, the 20 years that NICE has been producing advice on new technologies, you can see that down the left-hand side of this table, we either say yes, so we're pretty much saying yes to anything that a new technology offers, or we're saying yes with conditions, so some aspect of the license is okay for routine use in the NHS. There are some technologies that go into the Cancer Drugs Fund, which I'll come back to in a moment, and then there are some circumstances in which we say no. And if you bring together those first three categories, you can see over 20 years or so, using this structured, objective approach to evaluating new technologies, we've been able to say yes to just over 80% of the technologies that we have looked at. So it's only a small minority where we simply can't see enough value to support the use of a new technology in the system. And if you look at it just for the cancer technologies that we've reviewed over that period of time, it's a similar but not quite so optimistic position. So just around 3/4 of the technologies that we've looked at, we've been able to say yes to over that period. And the principal reason for these two differences is the fact that for cancer technologies, companies are asking really significant premiums for sometimes very small incremental benefits, improvements that you can measure in weeks or a few months of extra life. Hugely important if it's you or if it's a member of your family, but when you're looking at it from a system perspective or a hospital perspective, very small incremental benefits for very significant additional sums of money. And in some circumstances, it simply isn't possible to justify the investment in the technology, even though for some patients there will be some measurable benefit in terms of a small additional period of life. Going back to that point I mentioned about Cancer Drugs Fund, in July 2016 in the UK, there was an attempt to try and improve the rate at which new cancer drugs were being introduced into the UK. And this new fund allows NICE to recommend cancer technologies, even in circumstances where we're uncertain about that additional therapeutic benefit. But if our advisory committee thinks that there's plausible potential for that extra benefit to be revealed with more data collection, with more clinical studies, if they think there's a real chance of that happening, then instead of saying, well, on the basis of the current evidence, we have to say no, they can say, on the basis of the current evidence, we're really not sure, but we think there's a possibility this technology might bring enough benefit to justify its price. So let's use this special fund for a specific period of time. And it's not just a way of getting around the standard yes-no procedure, because if technologies go into this fund, then companies have to agree a special confidential price, which won't be the price that they were looking for in routine use, and they'll have to sign up to a specific data collection protocol for a fixed period of time, at the end of which NICE will look at the technology again. So this is conditional on data being collected that justifies the value proposition that the company is looking forward to. And this is just an early example. Osimertinib, a treatment for lung cancer. You can see the schematic here is just illustrating the process. So in this case, there was uncertainty around overall survival and the generalizability of the data that was available for all patients that were included in the license. So our advisory committee recommended it for use in this special fund with a managed access agreement. And that managed access agreement has two components, a data collection arrangement of the kind that I was just describing, and that was that assumed additional data from ongoing clinical trials, and then also data collected on every patient treated through this special fund, which is routinely collected in the NHS. And then that commercial agreement, that confidential commercial agreement in which a price is agreed for the period of time that the drug is in the fund, whilst that data is collected. So it's a win-win situation for everybody, a win-win-win, if you like, for the health system. It's not paying over the odds. It's managing its risk for patients who are getting access to the treatment that they might otherwise not, and for the company who's selling the product, albeit not at the price that they necessarily want, but is getting the opportunity to use the drug in the UK market to demonstrate the value that it believes that the treatment's got. So it's one way in which the risk associated with the introduction of new health technologies can be managed by those who have to share that risk. It simply shouldn't be a simple transfer of risk from the company to the healthcare system. It's a traditional approach that companies tend to take. If you look back over the last 3 or 4 decades, we've spent huge amounts of money developing this drug, and it's now your responsibility, healthcare system, to pay for it. And you should believe us when we say that it's the right thing for you to do. It's not the right way to go about this. We need a mature relationship in which companies who are supplying sometimes fantastic new products work in a mature, grown-up way with healthcare systems. Don't simply treat them as a way of making money, but treat them as serious partners in the important endeavor of getting new health technologies to patients. So that's the Cancer Drugs Fund, and that's the approach that the UK takes. But I want to step now away from the specifics of the way NICE operates to offer some observations on how we can structure that mature relationship between the life sciences industries and healthcare systems. And I think, although again I'm speaking from a UK perspective, I think there is real application across global markets where there's a serious attempt to take an objective approach to assessing the value of new technologies as they're introduced into healthcare systems around the world. I think these are the key components. I'll go into these in a bit more detail, but dialogue is critical. It's about a conversation between companies who invested huge amounts of time and money, certainly, but they've got real emotional investment in the products that they're bringing to you as people who are running hospitals, to me, and the people like me who are helping you to make decisions about these new technologies. They want to be able to convince us, and to do that, we need to have a conversation. Those who make decisions for healthcare systems, whether it's at a hospital level or a system level, and those who are innovating and bringing new technologies to a healthcare system. The earlier that conversation starts over any individual product, the better it is. So however you go about making these decisions, signal to your life sciences industry partners that you are prepared to come in and let them talk to you about what's coming through their pipelines, what they think those new products are going to offer to patients, what they're likely to be looking for, even if it's not a specific price, some indication of where they think that product sits in relation to current technologies. An objective value assessment's important. Don't just take what the company says as being necessarily, absolutely the only thing you need to think about. Step back, put in place the best arrangements you can for taking an objective look at the data. And if you're not sure about the value proposition, then talk to the company about how to share the risk. Don't simply assume that you just have to accept that. It's perfectly possible to structure arrangements in which that risk is shared between the company and the healthcare system. Think about where the new technology is positioned in the care pathway. It may have a game-changing effect on the way patients are treated. It may have a fundamental impact on what people do and how resources are allocated inside the institutions that you're responsible for. It may just have a marginal impact, but you need to understand what that is before you make a final decision. And then think about how that new technology is going to work on a case-by-case basis, and think about the way in which you can really inform the judgment that's made by patients about what they need to manage their care. So who needs to be involved in this? Well, I realise that, speaking from a UK perspective, we've been in the lucky position of having a well-developed academic base to start considering how to assess new health technologies. It's a developed, quite well-structured, nationally funded healthcare to focus on the decisions that need to be taken about new technologies. But nevertheless, I think the components you can see here and the roles that need to be played by those who've got something to say about new technologies can be applied in almost any setting, including at an institutional level. Clearly, clinicians need to be involved in it. Their perspective is critical. Their understanding of clinical practice, of the science and the needs of their patients is hugely important. But patients themselves have a critical role as well in helping to inform the decision that's taken, particularly in circumstances where judgments have to be made about the value of a new technology. Their perspective on what's important to them as patients or to us as patients is really very valuable. What do you need to look at? And what priority order do you want to consider the new technologies that are rolling out of company pipelines, that are increasingly being developed by new players in the life sciences industry, people who are developing digital health technologies who've got no track record of the kind that the pharmaceutical or the medical devices or the traditional diagnostics industries have got. So what of those new technologies are you interested in? How are you going to prioritize them? Take advantage, if you can, of the academic infrastructure that you can access locally. There are people there who, right across the world, who are interested in objective approaches to assessing new technologies, who would be prepared to work with you on that. And then don't exclude companies in these conversations. There are places around the world where the idea of talking to a company at all, let alone involving them in the process of making a judgment, is a complete anathema. And I know that around the world, the relationship between companies and healthcare systems can be difficult for one reason or another. But if you can engage companies, if you can say, here's a space that we can have a conversation that doesn't compromise you and it doesn't compromise us, will almost certainly bring benefit. Increases trust, it'll increase your knowledge about the technology, it'll draw the company into the objective and transparent processes that you want to put in place to evaluate new technologies. And ultimately, I think it'll make for a better quality decision. So what about aligning for successful adoptions? I mean, this is an enormous market, $1.5 trillion by 2022. All that money is coming out of somebody's pockets, either directly, indirectly through health insurance, or indirectly again through taxation in state-funded healthcare systems. It's really important that that money is spent effectively. We can't just assume that one party knows the right decision, whether it's the company, whether it's an individual clinician, whether it's a patient group lobbying for the use of a technology. All of those players have got a perspective on the decision that's making, but none of them have a monopoly on wisdom. They should all be involved. Everybody's perspective should be taken into account. There's definitely a shared interest between companies and health systems and the hospitals that deliver services in getting this right. We need to make sure that we send a signal to the life sciences industry about what matters, about what we're prepared to pay for and what we're not prepared to pay for, about what constitutes real, valuable innovation and what's simply just a way of companies making additional money in circumstances in which insufficient value is being brought to bear for patients. And then think about it from the company's perspective. If you're a global company, you've got 100+ markets to work in, and you're getting 100+ signals, all of which are different, and you somehow got to make sense of all of that as you think about what products to develop and how to structure the value proposition. Now, I'm not suggesting that globally we can go about creating a single approach to valuing new health technologies. I don't think that's possible or necessarily desirable. But it's worth those of us who are making decisions for individual institutions or for national healthcare systems to remember that companies are working with multiple markets and to bear that in mind when we're having the difficult conversations that we sometimes have. And ultimately, the relationship that we create between our institution, our healthcare system, and the life sciences industry can either enable or frustrate access to new health technologies. We can make it easy by not bothering to ask questions about new technologies, but we risk misusing the resources that we have available. And we risk presenting false hope to patients in circumstances in which the only thing that we're presenting is the company's claim for a new product, inappropriately or unbalanced with a broader objective perspective. We can enable access to technologies when we've got a really mature relationship with the life sciences industry and we've got an objective approach to evaluating their new products. And problems occur when these things aren't in place, where we're not clear about what we want, or we're not clear about how we're going to make decisions about the introduction of new technologies. It happens when companies themselves are not thinking about the realities of individual markets. It may be complicated for them, but they have to understand that decisions are taken in different ways and they have to tailor the value proposition for the market that they're talking to. Companies have to think about what they want for their products. Not in every case, but there are still too many cases where companies are presenting value propositions to us. We've got decision-making responsibility. They're simply asking too much for the additional therapeutic benefit that these technologies are bringing. Companies need to really think about what they're looking for, because what they're looking for is stressing healthcare system finances. And it's going to continue to be the case, particularly as new precision medicines are being developed for tiny populations in any individual jurisdiction. But companies are looking for huge sums of money for those technologies. We've got to think about how to manage this, and it's not just the responsibility of the healthcare system to find ever more money to feed that particular machine. The life sciences industry have got a big responsibility to think about their commercial model and to think themselves into the shoes of people like you who are managing resources that are already really tight at a local level, or people like me that are trying to help you do that at a national level. They've got to think about what it's like to be in that position. And if they do that, then I think there's a real chance for a much more optimistic, mature relationship between health systems and the life sciences industry that can work really well for both parties and make sure that these great new technologies can get through to patients quickly. And how can we do that? Well, greater clarity about our ambitions. We need as healthcare systems to be clear about what our priorities are, about how we establish value, and about what we're looking for from companies. Are there circumstances in which we're prepared to pay premium prices? What circumstances are there in which we're not prepared to do that? That clarity is hugely important if you're a company working in a system. You've got to know that before you can start structuring your value proposition. That conversation I mentioned right at the beginning of this section of my talk about dialogue, again, is enormously important. The earlier you can start a conversation, the more you can share as a healthcare system about how you value their products, about what your priorities are, about what you think about a particular new technology and how you think it's going to fit into the care pathway, what you think it's going to displace in the healthcare system. What data are you looking for from the company and how are you going to assess it? It's perfectly possible to set that out for companies, and the more of that you can do, the earlier you can do it upstream before you even start making the decision through objective science advice and market access services, the more likely it is that you're going to be able to make a confident decision when you need to about the new technology. Closer working between regulatory agencies and agencies like NICE at a national level is important. Managed access arrangements of the kind I mentioned through the Cancer Drugs Fund can be a useful way of dealing with uncertainty, providing yourself with a back pocket resource that allows you to avoid the need to commit regular routine budgets in circumstances where you don't have the information. And then being clear about where a technology new fits into a treatment pathway is critically important. So final couple of slides, just some thoughts on how to get this right. A bit of a repetition, I know, of the things that I've been saying, but I think they bear repetition. Shared value assessment should be the basis of access decisions. It's no one party's decision. We shouldn't be excluding anybody who's got a perspective. We as the decision makers, locally or nationally, shouldn't be excluding professional groups, patient groups, or the companies themselves in the decisions that we make, because the more perspectives we can bring to bear, the better it is. And you can do that without compromising, without being accused of being rolled over by a particular stakeholder, whether it's a company or a professional group. If you structure a safe space for a dialogue to take place in an independent and objective way, it's perfectly possible for those perspectives to be successfully brought to bear, and everybody feels that they've had the opportunity to say something, and nobody feels that they've been compromised as a result of that. Companies need to know how you go about making your decision. They need to have structured opportunities to engage with you. The more you draw them into your decision-making process, the more you'll engage them in that process of managing the risk and sharing the risk of introducing sometimes very expensive new technologies into the system. Companies have got a big responsibility to understand the impact of their new technologies on healthcare systems. And if they want a sustainable relationship with their market, they've got to think about ways in which, particularly the very new expensive technologies, are actually going to be afforded by healthcare systems. Technologies that now are claiming lifetime benefits for patients are going to stress healthcare systems at the point at which companies are currently expecting payment. Can we be more innovative about thinking about ways in which health systems can pay for these technologies? Can companies be more realistic about their ambitions for returns on the investment that they make for those new technologies? Sharing risk is critical. And then just finally, at a hospital level, what do you need? What are your priorities? How do you organize your clinical communities to think objectively about the new technologies that are coming in? Mostly clinicians will be routinely enthusiastic about using new stuff coming through, but they are all aware of the fact, through their experience, that not everything brings everything that's claimed for it. So they will be prepared to share in an objective approach to valuing the incremental benefits of new technologies. And if you do adopt something, then don't just regard that as the end of the decision. Make sure that you are collecting information about the use of the technology and its benefits, so that you can loop that back into an assessment of whether you've got the original decision correct. Be clear about how you're going to use the new technology before you start using it, particularly where there's a significant resource impact, whether that's the headline cost or the headline cost plus significant disruptive consequences elsewhere in the care pathway. Make sure you understand what that is, and you've got systems in place to manage the positioning of a new technology in the system through some process of using clinical guidelines. And then obviously make sure that you've got the commitment from those who are funding your institution, locally in the institution itself, and those who are paying for the services that you provide. So, again, thank you very much for the opportunity of talking to you today. I hope I've given you some indication of the approach that you can take to structure a really good quality and effective relationship with the fabulous life sciences industry. But if you take away one thing from this, take away this. Unless you talk to them, unless you involve the life sciences industry in your decision making, you'll miss out on something hugely important. But make sure that in that conversation you're clear with them that you've got a great process for valuing their products, that you expect them to bring a really good value proposition, and ultimately you're going to expect them to share the risk of the uncertainty associated with their products as they move into your services. Thanks very much.